Good evening, all. So, welcome to case-based discussions. Today's topic is about status epilepticus. I'm audible.
Yes, sir.
Yes, sir.
Screen is visible. Slides are moving.
Yes, sir.
Yeah, we'll start the session. So this is about an 8-year-old child. He was brought to us with complaints of fever for past 2 days, and child is having dull activity and seizures for past half an hour. Child was brought from the home to the hospital, and there's no past history of seizures for this child, and there's no history of trauma as well. So this is the initial impression. So child was actively seizing. There's increased work of breathing, which stridor, and peripheries are pale. So the question now is, what is the physiological status of this child, and what are the interventions you want to do now?
Unstable life-threatening condition.
Yeah. So how will you intervene now?
We'll give first intravenous midazolam, sir, to stop convulsion.
Immediately.
Sorry, sir. Nasal midazolam spray.
Okay.
Secure airway. Start oxygen.
Yeah, always go in the plan of ABC. So even your status epilepticus management, the initial stabilization is ABC. Then only your treatment of seizures occurs. So what is the problem here in ABC here? Someone has answered oxygen, airway to be secured. So why this child is having stridor? What are the cause of stridor in this child? And you need to work out breathing. Falling off tongue. Okay, accepted. Anything else? Central cause. So how central cause will cause now? Stridor. Secretions accepted. Upper airway obstruction due to secretions, bronchospasm. Yeah, accepted. Anything else for increased work of breathing? For stridor, these are sufficient. For increased work of breathing?
Aspiration.
Exactly. So aspiration is one of the possibilities. So first thing is the immediate management. What we can do is, so we can put the oxygen, and how to decrease the stridor.
Tongue positioning.
How will you position?
Goodell's airway.
Yeah, good. Clear the airway by doing suction. Exactly. Anything else can be done? Positioning is, yeah, exactly. So left lateral position, it might prevent the further aspiration risk, and you have to open the airway. Main thing is that making the airway straight. So the most important positioning is very important. Apart from that, you can apply your airway, oral airways. That's all. So same thing. So you start the oxygen, put the lateral position, do the oral section, and immediately you have to ask for IV cannulation. So that's the most important thing before you go for primary assessment. You have to tell one of the person, your assistant or staff nurse, to go for mechanism for IV cannulation. So this is a primary assessment. So airway is becoming maintainable with suctioning and positioning. So mainly it's the problem with the obstruction secretions and tongue fall most probably. So breathing is okay with minimal stridor, Retractions are there, but SATs are maintainable. And circulation is fine with some cold peripheries and normal CRP. Little bit higher side BP. And disability wise, child was in general tonic-clonic seizure, where GRBs is normal, and child had fever also. So, how will intervene now? What your assessment and how will intervene? So, what is your assessment respiratory wise? Respiratory, what is the assessment? Yeah, it is respiratory distress. Circulation wise, is there any issue circulation wise? Come on, we have to move on. This is not the main discussion today. So I don't think any issue with circulation. What is the problem with your nervous system? Is it primary dysfunction, secondary dysfunction? Then the main problems identified is respiratory distress with primary cerebral dysfunction. So what treatment you are going to give? So you are going to control the seizure. So if you secured IV access, we'll try to give lorazepam and control the fever and thinking of the DDs of meningitis. So we'll try to give an antibiotic as well. That is what normally we'll do. So how to define status epilepticus? So what is the definition of status epilepticus?
Continuous convulsive activity without regaining of consciousness.
For how much time?
5 minutes.
5 minutes. Okay. What definition it is? When it was proposed?
2000 ILAE class.
When it was proposed?
2017.
2017.
No.
That's not the recent definition. Anyone know?
19.
Before this definition, one more definition was there. Time period.
15 minutes before it was. Half an hour, sir.
Half
before
an
it.
hour. Before said half an hour, then came down to 5 minutes, and now the definition was remodified again in 2015 ILAE. So they remodified it again. That is the latest thing. Definition proposed. Anyone know that what the definition is?
Continuous persisting is 5 minutes or one more further episode within 5 minutes. Previous incident.
Your voice is breaking.
It's a continuous seizure activity of 5 minutes or again one more episode within 5 minutes of previous seizure activity.
No, that is the old definition. That is called operation definition. The classical definition is half an hour. Operation definition is 5 minutes. Now they redefined in the latest ILA proposal in 2015. They redefined. So they not talking about this this one now. They're talking about the pathophysiology. So they completely taken off this continuous seizure part. It's accept the continuous seizure is the what thing we can do, but for defining status epilepticus, they taken pathophysiology of the consideration. So what they're telling is Status epilepticus is a condition resulting either from failure of the mechanisms responsible for seizure termination or from the initiation of mechanisms which will lead to abnormally prolonged seizures. So when you call status epilepticus, if a seizure has sufficient duration where it will fails, the mechanisms are failing to terminate the seizure, or there is initiation of mechanisms which will abnormally prolong the seizure. So they put this at time point T1. So time point T1 is where your seizure is getting prolonged abnormally because either it is a failure of the mechanisms or initiation of mechanisms which can prolong it. And they give one more time period T2 where they tell if the seizure prolongs this time, it will have long-term consequences. It can cause neuronal death, neuronal injury, so many things, and it can cause the brain damage and it has sequelae. So our main aim is when you have to start treatment, T1 or T2?
T1.
Our main aim is to start the treatment at the T1 and not to make the child progress to T2. The child progress to T2, you're expecting a lot of complications. So that's why you need to stop at T1. So practically, what is the definition now? Status epilepticus. So for conventional status epilepticus, what is the time period now? T1. T1 is for convulsive status epilepticus, it is 5 minutes GTCS. And for focal, it is 10 minutes. So your time period is changing. So previously, this for every seizure it is 5 minutes. But now, based on the pathophysiological mechanisms, they slightly modified the time. So for the GTCS, it is still holds good for 5 minutes operational definition. And focal, it is 10 minutes. And for absent seizures, it could be 10 to 15 minutes. And the time period T2 for GTCS is 30 minutes. The previous classical definition is 30 minutes. That's why they remodified it to 5 minutes. Because if you start treatment at 30 minutes, you're already encountered the neuronal damage. And for focal seizures, it could be 60 minutes. Why this is very important? Why these time frames are important? Anyone? For logical reasons. Why time frames are important? Is they important or not for us?
For neurological outcome of the child.
Yeah, how it's going to tell us? How it's going to define your management?
Treatment in order.
Yeah. Example, if a child is in GTCS, if a child is in focal status, so how your management is going to change? It's very important. So that's why if you I don't understand this. Yeah, drugs. Yeah, drugs are same for any status. It's not going to change. How fast you are going to give the drugs, how faster and how aggressive you are going to manage, it's going to depends on your T2. So if the child is already in half an hour duration from the home to here, you need to be very aggressive and you have to keep pushing the drugs as faster as possible. Understood? You cannot give like drugs for give it over half an hour. We'll see. You have to give slowly because they have complications. I cannot monitor here complications, so give it slowly. There's no point of giving slow administration of AEDs when you are already reaching the 30 minutes time. So it's defined. It's very crucial. The time period is very crucial. So you need to rush on aggressive management of status epilepticus when your T2 time is reaching. So that's why the time frame. If you have focal status, fine, you have more time, so you can go slowly. If you're thinking complications of the drugs what you are giving, but in case of GTCS, the time frame is very less, so we need to rush on the drugs. So that's why the protocols are modified now. The management protocols are modified based on this identification of the time frames. So what are the other IV options you have here? So we prefer IV lorazepam here. What are the other options you can give? Other IV options.
Midazolam.
Midazolam. And any other thing is available? What group of drugs are there? Midazolam, lorazepam.
Benzodiazepine.
What is the other benzodiazepine you can use?
Diazepam.
Diazepam. How they differ? Is there any difference for these three drugs?
Onset of action and duration of action.
Yeah, very good.
Time of onset. Route of administration.
Yeah, we are talking about only IV now. So I'm talking about only IV options. We have three options, IV option. The first answer is absolutely correct. Any other thing? Second, yeah, someone answered correctly. Respiratory depression. Which will have less respiratory depression? Among all the three, which will have less respiratory depression?
Lorazepam.
Exactly. That's the most important complication we want to avoid and we want to anticipate by giving these drugs. So lorazepam. So that's why we prefer lorazepam ahead of midazolam. But they both have like more or less similar onset of action, and duration is lorazepam is a higher duration than longer duration than midazolam. Diazepam little late onset and it's in between duration. So that is the main difference for these drugs. So if you have option, the first option we have to choose is lorazepam because the safety effect and there's not much difference from the efficacy and onset of action with midazolam. Not much. Midazolam is the faster compared to lorazepam, but for safety purpose, lorazepam is a better option. So coming to pathophysiology of status epilepticus, the main pathophysiology is multifactorial, and the main mechanism proposed is receptor trafficking. So what is this trafficking? We'll just see in the next slide. And also extrusion of anticonvulsants across the blood-brain barrier. So these are the mechanisms which will unduly prolong the seizure. So normally seizures will self-terminate. If you have any seizure disordered child, they'll have multiple seizures in the home, multiple, like refractory epilepsies. So all need 3 to 4 drugs will be there, but they'll keep on getting seizures, but they will never come to hospital for the status. You will self-terminate by themselves. But if the child coming to hospital in a status, that means there's a problem with the self-termination. There is unduly activation of the mechanisms which will prolong the abnormal prolonged seizures. So what that mechanism is this one: receptor trafficking and extrusion of anticonvulsants from the blood-brain barrier. This is what receptor trafficking is. If you have prolonged seizure, your GABA receptors will move in. So the cell membrane receptors of GABA will move in. So you cannot, your benzodiazepines will not work here. And you have activation of NMDA receptors, which are inside, they will come out. So NMDA is an excitotoxic element, so they will cause excitotoxicity. So if you give benzodiazepine at this moment, it will not work now. So understand what I'm telling? So if you see that is unduly prolonged and you benzodiazepine receptors are already got into the inside the cell. So there's no surface benzodiazepine receptors, GABA receptors. So how many times you're going to give your benzodiazepines, they are not going to work. And the drugs which will act on GABA are also not going to work. So you should know what is the mechanism of action of all the drugs. AEDs. It's very most important to manage these status children. And we need to act on the NMDA receptors now. So we need to switch over from the GABA to act on the NMDA receptors. So that's why you need to be aggressive in managing status epilepticus. So there will be damage to blood-brain barrier, neuroinflammation, all this will cause poor outcomes. And why this pathophysiology is important? So what it will tell us is, status epilepticus is a time-sensitive emergency. You have to be very careful and should not delay in management. And if treatment is delayed and inadequate, so they will become self-sustained and they will fail to respond to all the mechanisms of seizure termination, and even they will not respond to your suppressive drugs. So that's why it should be very careful in managing status. You have to be aggressive. And over the time, like we discussed with receptor trafficking, your benzodiazepine potency will decreases and the need for NMDA antagonists will increase. So what are the complications of stress epilepticus? So we know if it unduly prolonged, it will cause neuronal damage. Apart from that, any other complications we encounter in stress epilepticus? No. Yeah, exactly. Neural, apart from neural aspiration pneumonia accepted. Next, you have to think what is the problem happening during status and how it can modify the pathophysiology of our body mechanisms. Hypoglycemia, fine, exactly. Hyperthermia, good. Then we move on. It's going to involve all your body mechanisms. It's going to involve every part of your every organ in the body. So it will going to increase the energy consumption. So the hypoglycemia is expected. The excessive muscle contraction, that's the main pathophysiology. Because you have excessive muscle contractions, they can increase body temperature. Hyperthermia, it will further damage your other body organs. Hyperkalemia and increased myoglobin causing AKI, increased catecholamine, then cause stress cardiomyopathy. That's why you need to be very careful when you prolong status. When you're giving these AEDs, which will also depress your myocardium and hypertension, be very careful. And even GIT, it can cause ileus and ischemia. So finally, decreased ATP, which will cause hypoxia, acidosis, anaerobic metabolism, and will cause further damage. So these are the common pathophysiological things which will be involved in status epilepticus. They can damage literally any organ. The prolonged status can damage literally any organ. So we need to terminate it as early as possible. And if you're not able to terminate, you have to look for all these complications and you have to manage this supportive management for these complications. Okay, unfortunately for this child, we couldn't able to secure IV line or IV access. So what options we have now? If you're able to secure IV access, fine, you can directly go for IV options and even IV access. But if he is not able to secure anything for this child. Exactly, nasal midazolam, IM midazolam, rectal diazepam. Any other option? Nasal, rectal, IM. One more option was there.
Buccal.
Yeah, buccal. Which is best one here among all these four? Among all these four routes, which is best? Buccal, rectal, no. IM, fine. So, first of all, compared to diazepam, midazolam is the best. In midazolam, IM is more I cannot take like efficacious, but IM is the more preferable option than nasal, than buccal. So that is what the recent guideline proposed by American Epilepsy Society in 2016. So what they told is the first line they given IM midazolam, IV lorazepam, and IV diazepam. Then second line they given this nasal, buccal, and rectal. So always, if you're not able to get IV access, at least try IM midazolam. The same preparation you can give IM, and but we need more concentration more. If you have more volume, and even nasal, you need to more concentrate. Normally, we'll have 1 ml, 1 mg preparation. 1 ml, 1 mg preparation, but one more preparation is available vials, 1 ml, 5 mg. So that preparation, ideally, we have to use for this nasal, IM, and buccal preparations because we need to have less volume. So please, if you're not able to have that, try to procure them. So 1 ml, 5 mg preparations, ready-made available. So that can be used for these other routes apart from the IV. So this child we got the IV access, given IV lorazepam, but there's no response. It is not terminated. So what we have to do? Come on, we have to move. Yeah, after 5 minutes, you can give second dose of lorazepam. Fine. So these are the first line drugs, and these are the common preparations and doses. What I want to stress is IV midazolam dose is not 0.1. You have to go up. You can go up to 0.15 to 0.2, and IM is also same. But when you're giving nasal and buccal, it is little bit higher, 0.2 to 0.3. So the maximum dose is 10 mg. So I seen commonly on nasal, we are prescribing only 2 puffs, 3 puffs. How much of the nasal spray is available, midazolam? How much one spray will give? How much dose it can deliver, one spray? Ready-made nasal preparation. All of you know that this nasal, ready-made nasal sprays are available for midazolam, which you can give to for home for this febrile serious children.
0.1 ml will give 0.5 mg.
Yeah, one spray is going to give 0.5 mg. So you need to calculate according to the body weight. You cannot tell blindly, do 2 puffs, 3 puffs. So you need to calculate for the body weight, and you have to advise the parents how much to be given. Like for a 10 kg child, if you take 2 mg, like a 0.2 mg per kg, so it comes to 2 mg. 2 mg means 4 puffs. So you have to advise at least 2 puffs in the 2 sprays in each nostril. So like that, we need to tell the parents. So maximum dose is 10 mg. So for a status refractory epilepsy children who have frequent seizures in the home, you can advise this nasal sprays. It's simpler for the parents to use. So it is readily available. The chart is available. You have to make your own charts and keep it in your ER emergency room so that you don't have confusion how much dose to be given. And for this child, we given 2 doses of flurazepam, and your seizure is not terminated. So what next? So what do you want to do now? What are the other options? I want to know what are the options you are using currently in your setups. We have given 2 doses of benzodiazepine, seizure not terminated, and what are the options we are using currently? So you are loading with some AED, phosphenitin accepted, Levipil accepted. So many are telling levetiracetam. Okay, fine. Any other options? Any other unit people can answer? Phenytoin. Still someone is using phenytoin. Okay, fine. We'll discuss why. What is the problem with phenytoin? Phenobarbital as a first line, I don't think now they're not using. Rapid sequence induction too early, but definitely in the future, I may tell they can go even with 2 doses of midazolam. They can go for rapid intubation, switch on to anesthetic drugs. Ketamine, no. Thiopentol when you decide to intubate, but according to the guidelines, what is second line? Second line, I'm asking. We are moving to third line. For second line is injectable non-anesthetic drugs. So phosphenitin, Levipil accepted, phenobarbital, a little less, valproate, exactly. So is there any unit is giving valproate ahead of phenytoin and Levipil? Valproate ahead of phenytoin and Levipil. So phenytoin and Levipil is commonly using. I want to know any unit is using valproate ahead of these 2 drugs. So which unit, Monica? Which hospital? I mean which hospital or college you are from? So you told you give valproate. Okay, fine. Okay, some people are giving valproate ahead of other 2 drugs. So the main thing is you should know what is the mechanism of action, what are the side effects. All are correct. Whatever you give, all are efficacious, equally efficacious in terminating the seizures. So no one is superior to any other drug here. Efficacy wise, all are same. But because of some advantages with levetiracetam, so even the recent guidelines, they are considering Levipil ahead of all others. We'll see how it is moving ahead of other drugs because of safety profile and fast administration. So these are the second line drugs which are available, and these are the dosing. These are the guidelines from American Society and UK guidelines. And so phenytoin, you need to give over 20 minutes. Phosphenitin, you can give over 10 minutes. Valproate, the dose is now not 20 mg per kg, it is 40 mg per kg. This you need to modify your, if you are giving only 20 mg per kg, you need to modify. So the valproate loading dose is what, because what we are doing now is we need to aggressively manage the status epilepticus. We should not wait for the status to prolong into the T2 phase where your neural development happens. Previously, you are giving a half loading, again repeating half loading, again one more loading. So they all now they're removed. So if you load with one AHD, you have to load it with the full doses. Don't hesitate to load with full doses. And Levipil also, it is not 20 mg per kg, it is 40 to 60 mg per kg. And depending on the 40 to 60, your maximum dose varies here. And you can view it in 5 minutes. That's the best advantage of Levipil. So before, if you see phenytoin 20 minutes, already you're reaching T2 time. By the end of 20 minutes, you're already in the T2 time. So, but Levipil, you have only 5 minutes. So even you have extra 15 minutes advantage. So you can give one more drug or you can start medicine in 10 minutes. So that's why the Levipil is going ahead of all other drugs. And safety profile as well. So comparison of levetiracetam was phenytoin. It's already been discussing. So we can begin faster in 5 minutes. Fastest, like faster onset of action compared to phenytoin as well. Well tolerated, equally efficacious. But don't think we are giving Levipil because it's superior to phenytoin. It's not superior to phenytoin. It is as efficacious as phenytoin. But because of this faster administration and faster onset of action, which was studied in Eclipse and Concept Asset trials with the recent landmark trials in 2019, where they published this. After publication of these 3 landmark trials, now the recent UK guidelines, they changed the second line drug. The first choice of second line drug is Levipil. That is the reason. So comparing to phosphate to phenytoin, what is the difference between phosphate and phenytoin? Why we have to choose phosphenytoin when compared to phenytoin? And what are side effects of phenytoin? What do you have to do when you are giving phenytoin loading? What do you have to monitor? Hypotension, pain, exactly, pain injection site, heart rate, exactly. So they will cause bradycardia, rhythm abnormalities. So think when giving phenytoin, you need to think about cardiac changes, cardiac ECG changes. So be careful when administering phenytoin. So that's why we need to switching over to safer options now. So like phosphenytoin. So phosphenytoin can be given faster and it was better tolerated, less local as well as cardiac side effects. So that's why many units are switching over to phosphenytoin if you want to give a phenytoin drug. So this child will given 40 mg per kg levetiracetam over 10 minutes and seizure not controlled. And my question here is, when you are giving levetiracetam, whether you can give one more dose of IV lorazepam. Say we given 2 doses of IV lorazepam and we start a levetiracetam infusion and we are giving it over for 10 minutes. Say we are giving 10 minutes, and after another 15th minute, can we give one more IV lorazepam if it is continuing? Can anyone given this kind of phenytoin we are giving 20 minutes, and in between phenytoin loading, like say after 5 minutes or 10 minutes, we are giving lorazepam or midazolam? Someone answered no. Why? Why no? Why can't we give? The previous teachings and previous professors' recommendation is to keep continuing midazolam IV for every 5 minutes till your seizures get terminated, even if you're loading phenytoin. But the recent recommendation, recent guidelines, they're not telling exactly we should not give, and there's no consensus. So ideally, if your child is having already respiratory depression and you're afraid of going for RSI in the peripheral centers, I tell you should avoid giving extra dose of lorazepam or midazolam, and because already you're giving a different acting AED, so preferentially give faster levetiracetam than choosing extra dose of lorazepam, because again respiratory depression, if you're not able to secure airway, it's a more problematic in peripheral centers. But in tertiary care centers, I don't feel you can try. But it's not like there's no guideline which can tell that you should try this, but no guideline is telling, not recommending. But for logical thing, when you're not able to manage with AEDs, you're going to do infusion only. So why not? That's the question here. But I cannot watch for this. There's no guideline is telling whether you need to give extra doses of lorazepam when you're. But there's some recommendations, some guidelines are telling you can continue. So that's up to you. That's up to you about your management of airway. So answer you can tell is no as of now. And what you can call these test subjects now? After giving 2 doses of lorazepam and 1 dose of uploading dose of levetiracetam, still cells are continuous. So is there any name you can give for the status now?
Refractory status epilepticus.
Yeah, refractory. Can you define refractory status?
Persistent status epilepticus even after giving 2 adequate doses of anti-epileptic drugs, and among them one should be benzodiazepine.
Is there any time period?
For more than 60 minutes, sir, but best option is while defining is about
The
to
previous
define
is
it.
more than 60 minutes. Now they're taken off. Now with the changing definition, they're taken off all these things. Now there's no time duration. Even after 15 minutes, you can call them. If you're given Levipil over 5 minutes, at the end of 15th minute, you can call them as refractory status. So that's why the time period is taken off now. Definition is correct. So what next? So whether you want to view one more AED, non-anesthetic AED, or you want to give continuous anesthetic infusion. What are the options? What is the practice people are practicing right now? So at the end of Levipil, or say you are giving phospheniton or phenytoin. So you given 1 loading dose, 2 doses of lorazepam or midazolam, and CS are not controlled. You labeled as refractory status. And what is the next approach for refractory status? Whether you want to try one more drug which is non-anesthetic, or you want to start immediately continuous infusion. What is the consensus say? What are the latest evidence say? And what is your practical thing? What you are practicing in your setups? Not responding to first line aid is midage infusion. Okay, very aggressive. Any reason for that? You have tertiary care PSU setup. Phenobarbital, one more AED. No, I just want to answer from Hima, who answered midage infusion. Why midage infusion? Why you choosing midage infusion rather than one more drug, phenytoin or valproate loading? Hima, you can answer. Refractory status to so midage. No, that's why I'm asking. Why not other loading? Because others are telling they can go for anesthetic AED. They are also correct. Absolutely correct. They are not wrong. But you are also correct. How to justify your answer? That's what I'm asking. How you will justify that answer? Is there any particular reason for directly going for midazolam before trying any other non-anesthetic drug? Or you're just following a guideline where they tell if PSU setup was there just to go for infusion rather than loading one more AED? It's okay. You don't want to answer. Fine, we'll move on. So to answer this question, we need to have literature search. And in the literature, the data is very less to guide this decision. And there are numerous options we have, even on the anesthetic drugs. And so you know already the pathophysiological mechanisms. If you delay the treatment, the response to the drug is going to decrease. And so you cannot use that much amount of time for a seizure to prolong. And in convulsive status epilepticus, early escalation to anesthetic drugs is justified because you should rapidly control seizure activity to prevent the damage to the nerves. Because you know the time period T2 is only half an hour for constant GTCS. So you cannot delay more than half an hour. If you start loading with phenytoin and you waste one more 20 minutes time for that, and already you are in the T2 time period, so that's why your neural damage can occur. So that's why based on this, so anesthetic drug like midazolam is more preferential than non-anesthetic AED when you have set up for airway maintenance, like a proper tertiary care PICU. If you have that opportunity, my choice is directly go for midazolam infusion. 2 doses of benzodiazepine, 1 dose of Levipil, faster, that in 5 minutes. And if you are not able to control, if you have PICU backup, you are well versed with intubation, directly go for midazolam infusion or any other drug, thiopental, that's also fine. That's your choice. But commonly, what will go in our setups like medical colleges, we have only midazolam, so preferentially midazolam infusion. But you should know your you have airway skills, remanent skills, and PICU backup. But if you don't have these two things, you obviously have to go for second line, one more second drug, anesthetic drug. Or if you have tertiary care setup as well, but the patient is little hemodynamically stable and it is preserved and he was adequately oxygenating, ventilating, and it is not harm in trying one more AED like phenytoin or valproate. So that is what the recent evidence tells, that if you are well versed with airway management and PICU setup, directly go for anesthetic drug like midazolam. If you don't have that setup, you can try 1 or 2 other drugs. And even in tertiary setup where you have PICU, if a child is relatively stable and you feel that you might terminate the seizure, and the child is not that very late to the hospital, child came early to the hospital, you can try one more drug, either phenytoin or valproate. So that is what the evidence, and this is what the suggested algorithm. So convulsive status, directly go for anesthetic AED like midazolam, and non-convulsive, like child was EEG showing non-convulsive status, and child was in coma, you can give a trial of one more drug, anesthetic drug. And child is conscious or partially conscious, you don't need to go rush for the anesthetic AEDs, you can try non-anesthetic AEDs. This is for the recent guidelines suggest. So here we chosen a safest pathway. We loaded phenytoin until seizure was not controlled. So what next? So obviously the answer is to start on midazolam infusion. Okay, we started on midazolam infusion. Seizures are not getting. How will you start midazolam infusion? How will you start? I think many people are using midazolam infusions. How to start? Directly start midazolam infusion, or you want to do something else before starting midazolam? Yeah, always give bolus dose. Don't think that I given already 2 bolus doses of benzodiazepine. I will start infusion right now straight away. So always you have to give the bolus dose before starting infusion to get the your serum concentrations to the therapeutic levels. And how you step up midazolam infusion, go to me. How much time you are going to take to step up the midazolam?
Five minutes, sir.
Yeah, 5 minutes. And how to step up? How much mics you are going to start initially? Tell me first. Midazolam infusion dose, starting dose.
We will start minimum 1 to 2 to 3 mg per kg per hour, sir.
No, that is too much dose. You are confusing, I think, per microgram or mg.
Oh, sorry, sir.
Or minute.
We'll start with 2 to 3 mics per kg per minute, sir.
Okay, fine. So starting dose of 2 is fine. You can directly start with 2 mics per kg per minute. And every 5 minutes, you are going to step up to 2 mics. So 2, 4, 6, or sometimes they can go 4, 8. So whether you want to step up 2 mics or you want to double it each time, 2, 4, 8, 2, 4, 8 like that. So that is your option. And but before stepping up, you have to give one more bolus. So every step, you have to give one more bolus of midazolam. So like that, you have to step up. You want a safer approach, 2 mics. You want to get aggressive approach, you can step up aggressively like 2, 4, and 8. Or every 4 mics, 2, 6, 10, 14. Different protocols, different protocols. So stick to one protocol. That is what we needed. And when you have to stop stepping up midazolam, what are the endpoints of treatment of RSC? When you're going to stop the stepping up of midazolam, what are the common endpoints we'll follow?
Burst suppression pattern on EEG.
So that's the commonest thing. But if you don't have your EEG, so the most important thing is when you are starting an anesthetic infusion, we need an EEG monitoring, continuous EEG monitoring. The most important thing which will define and determine your treatment things. But many setups in India will not have continuous EEG monitoring, including government medical colleges and secondary level management things. So there, even the safest option is to choose at least a termination of visible seizures. So that are the endpoints. If you have EEG monitoring, you have to achieve burst suppression. If you don't have EEG monitoring, at least try for clinical seizure termination. So while you are on midazolam infusion, whether you need to give maintenance of levodopa and phenytoin, if you want to give, when you want to start, and how much doses you are going to start. You start on midazolam, you're stepping up on midazolam, and whether you want to give maintenance levodopa and phenytoin because already you loaded them, and if you want to give, when you want to give, after how many hours of loading, and what are the doses you are going to start. After 12 hours, fine. Dose. What is the dose of levodopa you are going to give? Please tell me what is levodopa dose. What are the doses of what is the maintenance dose of levodopa? Maintenance dose of levodopa. So everyone is telling 10 to 20, 20. So that's the main mistake, commonest mistake. So always start the maximum doses. Never ever hesitate to start maximum doses of maintenance. So you have to start at the maximum. If the levodopa, the dose is maximum is 60, you have to start 60. If some units can tell it, you can go up to 80, go up to 80. Never hesitate to start on the maximum doses. The main common mistake what you are going to do is we start at the lowest minimum, what are the minimum starting doses, and we slowly will keep on increasing with the recurrent seizures. No, the concept now, the clear-cut guidelines are there. You have to start maintenance doses of the loading drugs, or also if you're not loaded phenytoin, you can even start on phenytoin. So you need to keep adding one more drug when you are you control seizure and midazolam also. So we'll see how we are going to do that thing. But always try to put the maximum doses. This is the commonest mistake which is happening, and we need to correct ourselves. We also practice the same mistakes, but with the recent guidelines, there's a clear-cut evidence that you should go hit it hard. If you don't hit it hard, you are going to cause neural damage. So that's why always try to practice the maximum doses. You can start 8 to 12 hours after the loading dose. As early as possible, the minimum is 8 hours. So therapeutic target is there's no consensus regarding optimal target, and the endpoints are controversial and evidence is conflicting. So either you want to see seizure suppression or burst suppression or retrocerebral silence, that is up to you. But follow one thing, the commonest one which is following is burst suppression when you have EEG monitoring. If you don't have EEG monitoring, you can at least try seizure suppression. What is the maximum dose of midazolam we can go? Maximum dose of midazolam we can go. Come on, we're running short of time. So different guidelines say different things. So many units follow this maximum of up to 30, sometimes 36. IAP is 36. So what are the complications we'll expect during medullary infusion? Complications. Yeah, hypotension and respiratory depression. That's why when you're starting medullary infusion, you need to have airway secured. You have to secure the airway. So the most important thing is securing the airway. So when you're stepping up on the medullary, arrange for RSI, intubate the child, put on ventilator, then you step up on the medullary infusion doses. So that's why if you don't have an option of ventilator backup or RSI, please try to avoid medullary infusion. Do one more AED and try that thing, and as early as possible refer the child for the tertiary care center where they can manage this child. So for this child, we control the seizures at 6 mics per kg per minute. And the next question what arises is, what are the causes of this refractory status for this child? Or commonly, what are the common causes of refractory status epilepticus? How we can classify the causes? And what is the workup you have to plan for this kind of children? So what are the common causes of status epilepticus? In normal practice, what you see? Causes. First, we'll think about causes. Yeah, for this child, we thought of meningitis, possible. Any other thing? CNS infection, okay, meningitis, encephalitis, CSVT, good. How to classify this? First of all, before going for broad, so my way of teaching and way of telling to my residents and fellows is, whenever you ask something, you try to classify. So always put your mind that you need to approach anything with a classification, so that you will not miss all the causes. If you tell randomly, you are going to miss something. If you classify them and you know that 6 or 5 points in classification, you can always remember the causes. So that's why keep practicing this classification. So this will classify this like this: acute symptomatic causes, remote symptomatic causes, a child with a progressive encephalopathy, a child with febrile status, and a child with already known electroclinical syndromes like Levin-Tasset syndrome, Alport syndrome. And the last and not least important is the most important, is the most common cause of RSC now, is the cryptogenic causes, idiopathic, which includes your autoimmune encephalitis. So acute symptomatic is any acute illness, like what you were telling, like meningoencephalitis, traumatic brain injury, stroke, metabolic dysfunction like hypoglycemia, hypocalcemia, any poisonings. These are acute symptomatic. And remote symptomatic, child had already damage to brain, like RTA child has a gliosis. They can have this stimulation from the gliotic part, and they can have seizures. And post-stroke gliosis can also have this thing. And progressive neurologic disorders, neurocutaneous syndrome, they can have progressive neurologic disease, and they can go for status epilepticus. And commonly, you will see these febrile seizures, the febrile status children. They don't have any infection, but because of the fever, they can trigger the status. And most common cause now is cryptogenic, which includes autoimmune encephalitis and new onset refractory status epilepticus, NARS, and fights, febrile illness related status epilepticus, refractory status epilepticus fights. These are the common things which needs management with immunomodulation. You cannot only view like AEDs and this kind of autoimmune and NARS and fights. They need immunomodulation. So investigations, look for the baseline investigations, look for your total ionic calcium, sugar, sodium, and a febrile child, look for ILP. And the second line, you need an imaging, CT or MRI, depending on suspicion levels. And if you're suspecting IC bleed or ICSAL, you can go for CT, but if you're not suspecting them, directly go for MRI. And if you suspect toxicology, poisoning, you look for toxicology, and EEG is a must. And this is the first line investigations. And the second line investigations, so what we have to do is, if you're suspecting cryptogenic, you can send autoimmune panel, metabolic screenings, These are the things we need to consider. And how to wean midazolam. So the protocols are different. The different protocols ideally will start on 24 hours of the seizure-free period. And some sites say 10% per hour, and other tell the duration is more than 48 hours. It's been slowly, like 6 to 2 hours every 30%. And the duration is less than 48 hours. We can wean it fastly, like every 2 hours. So always remember, if it is harder to control the status, you have to wean very slowly. Even you can start weaning after 48 hours. But easily controlled status, you can wean it faster. Even after 24 hours, you can wean it. That's the main thing you have to remember. So hard to control, wean slowly. Easy to control, wean fastly. So steps, 24 to 48 you have to wean. And the most important thing is, before weaning, you wean any anesthetic drug, you need to have 2 to 3 non-anesthetic AEDs in your kitty. So without starting these 2 to 3 drugs, and without starting high doses, and without achieving the therapeutic levels of these drugs, don't attempt weaning anesthetic drugs. So they can go for recurrence or and again refractory things. They can, even if it's difficult to control them now. So once you achieve the control with anesthetic drugs, always try to put them on minimum of 2 drugs. Minimum of 2 drugs, not even 1. At least you have to keep at least 2 drugs. And if you need, you can add that drug also. And difficult to wean, like recurrence on anesthetics, and you have to keep increasing the drugs, 2, 3, 4 anesthetic AEDs. What are they? We'll see. What are the options we have? We'll see. And no evidence exists for the optimal combinations. It depends on your seizure type, is focal or generalized. What are underlying comorbidities? Like if you have a metabolic causes, we'll try to avoid valproate. So like that. And complementary mechanisms. So how they act synergistic or antagonistic, and drug-drug interaction, like phenytoin will decrease the concentration of valproate. So like that, we need to see what are the combinations you are going to keep. So, and you should avoid polypharmacy. So that's why you don't try to avoid more than 3. But in situations where you can't avoid, you have to go, can go up. So what options we have is topiramate, lacosamide is the most recent ones, which is moving ahead because of the different actions. They can suppress NMDA receptors. That's the most important thing. We need to now, the main GABA is already internalized, so we need to target NMDA. So that's why topiramate is moving ahead. And recently, brivaracetam and perampanel is coming up. And when you already started on a thiopentone infusion, and you can use phenobarbital for weaning that. And most importantly, you should have corrected underlying etiology. You should address the underlying etiology. Before weaning the anesthetic drugs, we should address the underlying etiology. We should know what is the treatment, what is the DD, what is the cause we are treating. And if it's infection, adequate dose of antibiotics should be given. And if it's CSVT, you should have started enoxaparin, anti-cerebral measures for the infarct, strokes, and autoimmune encephalitis, immunomodulation. So these are the things we need to consider before weaning anesthetic drugs, because if you don't treat the underlying cause, it's going to stimulate the seizures again and again. So that's why we need to be very careful when weaning the drugs. So for this chair, we done CT brain. It was also CSVT. LP was normal. So started enoxaparin. So gradually weaned off midazolam, and sensorium was completely normalized, and we estimated this child. So that will this will happen when you are very aggressive and manage the status in correct manner, and they'll improve like this. So they'll improve dramatically. So don't think that all CNS diseases are very bad and they will not have complete recovery. No. So it depends on your aggressiveness. If you aggressively manage and aggressively control the secondary complications, they'll recover very well, even including RTA patients. So that's what. And this is the etiology specific treatment. Metabolic causes, you have to correct hypoglycemias, hyponatremias, hypocalcemias, and IEMs, you have to avoid valproate. Traumatic brain injury, you need to control intracranial pressures, and have to control fevers in febrile status. Infections, you have to control infections like malaria, you have to give artesunate, herpes, acyclovir, autoimmune encephalitis, immunology. These are the supportive management for underlying treatment. If you don't treat the underlying thing, you cannot get the control over the seizures. So always try to identify the cause and treat the cause. And the last question is, what are the options we have if status is restricted to midazolam? So we keep on stepping up on the midazolam. We're going up on midazolam. We reach 30 mics. Is there any option we have? What are the options we commonly use in your setups after midazolam infusion? Thiopentone, ketamine. Good. Ketamine. So ketamine is now evolving. So we'll see what is the reason for the ketamine evolution. So these are the protocol. So status, refractory status, and even no control after IV anesthetic, some 24 hours, it becomes super refractory status. Once it becomes super refractory status, what the option you have is ketamine. One thing is ketamine, and the second thing immunomodulation, and the last thing are ketogenic diet, hypothermia, and your electroconvulsive therapy, other things. So these are the experimental treatments. But at least ketamine and thiopentone are the next options we have. And how to approach this? This is a simple algorithm which was proposed recently in 2020 IAP guidelines. And what they're telling is in midazolam, you step up and once you reach the maximum dose, you need to start ketamine infusion. So ketamine infusion, you're stepping up on ketamine infusion, no response. Then you need to go up on thiopentone. This simple approach. We can modify this approach. It's up to you. Whether you want to start thiopentone straight away or you want to start ketamine, because ketamine is the safest option. You can try ketamine before the thiopentone. And when you start thiopentone, you have to start decreasing midazolam. There's no point of giving midazolam and thiopentone together because both are hypotensive agents and both are going to act on the same benzodiazepines. So no need to give two drugs in the same fashion. So we need to give a different drug. Ketamine can act on the NMDA receptor. That's why now the preference is moving towards ketamine. So because of internalization of the receptors, so GABA receptors, where the other things are going to act. So ketamine has a different perspective, so different mechanism of action. So that's why we are trying to move towards ketamine. And if you have familiar with thiopentone, you can try thiopentone as well. But once you start thiopentone infusion, try to decrease the midazolam and give the minimum dose. Or you can stop it. There's no point of continuing midazolam when you're already on thiopentone. But don't combine and give both. And the next options are ketogenic diet and immunotherapy. And the targets is complete suppression of seizures. And if you have EEG monitoring, bus suppression. And you have to maintain the bus suppressions for 24 to 48 hours. And once you're decreasing and you have recurrence, again the duration increases. With every recurrence, the duration will go up 40 to 70 hours, 70 to 96 hours, like that you have to go up. And then slowly while well-being, you need to go up on your AEDs, non-anesthetic AEDs, you step up. So what are the options available? We have phenytoin, valproate, levetiracetam, lacosamide, phenobarbital, clonazepam, topiramate. So these are the recent options like topiramate and lacosamide. You can try them when you are not able to control with other two. And what are the options in resource-limited settings? How many of the government hospitals, government medical colleges has thiopentol and this ketamine? Is thiopentol available everywhere in any medical college? Even in private medical colleges? And just I want to know, because for that reason, so we don't have both. Fine, good. So for that purpose, what option recently proposed from AIMS, this is the AIMS proposal. So they did a study on this. When you don't have ketamine and thiopentone with you, always try phenobarbital. Phenobarbital is an excellent drug, very excellent drug in controlling seizures. It is similar to your thiopentone. So when you're not able to get the control on midazolam infusion, always try phenobarbital infusion. Infusion is, you can start at 1 mg per kg per hour and increase at steps of 0.5 mg per kg per hour every 6 hours and maximum dose of 3 mg per kg per hour. So this is what the proposed dosing, and this is from the AIMS study. It was published recently. So what they achieved is the EEG bus suppression. So that is what they did. And in this, they shown the 13 patients who was on phenobarbital infusion. Almost all are responded. Some needed some 10 minutes 1 mg, some 2 mg, and many needed more than 2 mg per kg per hour. It was published in 2018. This is from AIM study. So you can see here among 108 children, 34 only reached refractory status. Rest of all controlled with your benzodiazepines. And in 34, 21 controlled midazolam itself. Only 30, that is hardly 10%. So only 10% of status will need become super refractory, and they need all these measures. So rest of the thing will be controlled easily with the midazolam itself. So that's why more aggressive you are, the more the control you can get. You can taper midazolam, but ideally what I'll do is I just keep the midazolam at the lowest dose, like 3 to 4 mics. It can act as sedative as well. So we'll not going to stop it, but definitely you can taper. Once you achieve the control on the phenobarbital, you can taper midazolam, but not. I'm not going to stop it definitely. But that's your preference, to stop or not. That's your preference. But definitely I'm going to keep at the lowest dose, like 4 max, 4 mics. That's what my policy. If you got a good response with phenobarbital, I think you can also even taper this. And this is the summary. So stage 1, this was proposed in 2017, ILA 2017. So what they're telling is 5 to 10 minutes is a early phase, premonitory SC, impending SC. You need to start acting here. And if it crosses 30 minutes, it's established, 10 to 30 minutes is established SC. You need to keep hitting hard here in this phase. You should not allow the seizures to cross this 30 minutes. And if it is crossing 30, it has become refractory. You need to even more aggressive management here. And if it is crossing 24 hours, it becomes super refractory. So these are definitions based on the time period and your treatment they proposed here. And this is what I am telling. This is the recent 2021 and UK Resuscitation Council protocol. What they given, like our pulse, they given Resuscitation Council, they given this management. You can see here. Initially, you have to stabilize the airway. And 5 minutes, you have to have given these options, IV options, and second after 5 minutes, one more benzodiazepine. And you can see here after 10 minutes, they are giving levetiracetam. They are not giving the choices here. They are not given any choice here, Levipil or phenytoin. They have gone ahead and given Levipil as the first choice here. So after the second dose of benzodiazepine, they stated for you to Levipil. That's why the main reason for this is the publication of the 3 studies. 3 trials which given that Levipil is as efficacious and less side effects and given faster. You can give it over 5 minutes. The 3 reasons why Levipil is moving ahead of phenytoin. And what they given is, if you are not able to control with Levipil, you can try an second line agent if you don't have RSI. But if you have RSI, you can go ahead with anesthetic agents. If you don't have RSI and back up with PICU, always try to give phenytoin and phenobarbital, and you try controlling with this less anesthetic agents than going for anesthetic. But if you have PICU backup and if you have skills for intubating a child, definitely at the end of 10th, 15th minute, you can switch over to midazolam infusion if you have an option available. But if your airway management skills are less and you don't have PICU backup, always avoid midazolam. Go for safer options like phenytoin, phenobarbital. Phenobarbital is a very excellent drug, and you can meanwhile you can refer them in an ambulance to a center where they can manage. So that is what the recent guidance from UK Council. And once you have refractory, the options are propofol, but in kids propofol is very dangerous. They can go for propofol infusion syndrome. That's why we'll avoid propofol. Midazolam, ketamine, thiopental, and if you recently you can lacosamide, the drugs are coming up. So these are the options we have. And the take-home points from this talk is your IM midazolam is equal to IV lorazepam and IV diazepam. So you prefer IV lorazepam or IV midazolam because of respiratory depression. And the second line, Levipil, phenytoin, all are efficacious, but because of the safety profile and faster rate for administration, Levipil is taken over the other drugs. And don't try to give half-loading doses of AEDs. It's not useful. Always switch over to anesthetic agents if you have refractory status. And if you don't know the cause, if you're not able to identify the cause, LP is normal, MRI is normal, always try to immunomodulate them. The commonest cause of cryptogenic RSCs now is autoimmune encephalitis, NARS, and fights. These are the 3 options you have. They'll respond to your immunomodulation. So these are the take-home points. Thank you. If you have any questions, we'll take them.
Good evening, sir. This is Dr. Rusha, sir. Can I ask a I have a doubt, sir. Hello.
Yeah, please.
Sir, actually, you told that we load to the maximum dose. That means the maximum dose of levetiracetam is 60, and some textbooks and some are following up to 80 mg per kg, sir.
I think that 80 is
And
for maintenance, I feel. For
maintain-
loading, all the
okay.
guidelines is same, 40 to 60, what they're telling. Maintenance, someone comes, some telling 80, even 120, they are telling some units.
So loading means now when a child has come to us with status, should we load with 60 mg per kg per 60 mg per kg, or we should load 40? If it is not controlled, then we should give 20.
No, if you want, you hit hard with 60.
Okay. Is it same with the phenytoin also, sir? Phosphenytoin?
Phosphenytoin, the loading is only 20.
30.
Yeah, that's phenytoin equivalents. Phenytoin
Yes,
equivalent,
sir.
the 30 mg per kg, the phosphenytoin, and 20 mg per phenytoin equivalent.
Yes, sir.
There's no half loading again.
Okay, sir. Okay. Thank you,
Maximum
sir.
dose you can give.
Okay.
Even for focal seizures, yeah, definitely if they're not controlled and your child's consciousness is decreasing, definitely you have to go for anesthetic infusion. But before that, you need to try at least 2 to 3 drugs, 2 to 3 non-anesthetic AEDs before going for this. But if already the focal seizures are turned to secondary generalization, child started as focal but becomes secondary generalization, and your consciousness impaired, definitely you need to go for anesthetic agents. But if consciousness not impaired, like the flowchart what I suggested previously, you can try 2 to 3 different drugs, and I think phenobarbital will work better here in this kind of seizures. They have more action, but because you can go up on the phenobarbital loading doses. Some units prefer the loading at phenobarbital every 10 mg per kg, every half an hour to 1 hour again, reloading. So that is where you can try in this refractory status in focal seizures when consciousness is not impaired. So phenobarbital will work better in this kind of situations. But definitely if the child is going for respiratory depression and consciousness is altered, definitely you have to go for anesthetic infusion.